Afternoon, and welcome to the sixth of our weekly COVID panel discussions with key community leaders. This is an event organized by Tallahassee Memorial Healthcare and reflects amazing cooperation and collaboration across the entire Leon County healthcare community. We've got a couple other key partners I want to recognize. The Village Square, Liz Joyner's outfit there continues to promote civil discussion and discourse in our community, which is exactly what these sessions are about. And also Partners in Communication, which will have a sign language interpreter translating today as they have on past and future webinars. Finally, a special welcome to our radio audience on WFSU, which is broadcasting this Monday at 6:30 p.m. My name is Skip Foster. I'll be your moderator. You may have noticed my absence in the past 2 weeks. Big thanks to Gary Jordan for more than ably filling in for me. I was out because I got COVID, as did 3 of my family members. Their cases were mild. Mine was a little bit more moderate. I had a fever for about 2 straight weeks and required oxygen for much of that time. I made a couple ER visits, though I managed to avoid being admitted. I was sick. I was very sick, and only in the last 72 hours has my recovery accelerated. I want to thank Doctors Cody Van Landingham and Carlos Campa for amazing care, and to so many who prayed and had me in their thoughts. As serious as my case was, there have been so many that have had it worse, and far too many, of course, who have lost their lives. We're getting ahead of this thing, but if you get it, it's still very dangerous. So do what you're doing now, continue to be informed, don't let your guard down, and I can't believe I haven't coughed yet. So we're gonna get started and try to get you as much information as you can. Before we start, if you missed the first 5 webinars, you can find recordings of those as well as all sorts of information and FAQs at tmh.org/coronavirus. So we've had some news breaking here in the last couple days, and I want to start with that with Dr. Dean Watson, Chief Integration Officer at TMH and Capital Health Plan, as well as Dr. Trey Blake, the Chief Medical Officer at Capital Regional. And the first question, Dr. Watson, is the FDA appears poised to approve the new single-dose Johnson & Johnson vaccine. What can you tell us about that vaccine?
Well, I can tell you it'll be great news when it happens. It's a single-dose vaccine that uses old school technology. It uses an attenuated virus, an adenovirus, common cold virus, to deliver genetic material into the body so that the body can produce proteins, antigens, and then subsequent antibodies, which is what we've done for decades. So everyone, the great news is that this technology has been studied for a long period of time. We shouldn't be scared of it. We should embrace it. The outcomes using this vaccine are fantastic, even though people say, well, it's 70%, 72% immunity. Well, that's really, that's actually really, really good, looking at all the viruses that they have tested, or the variants of the viruses they've tested against. And even more importantly, as we've said on past broadcasts, is it's 85% effective in reducing severe disease, which translates into really no hospitalizations. And even the biggest number is 100% protection against death. And I'll take that every day of the week. So it's a great vaccine, and we're excited that it's a 1 dose, which will help with our distribution very much.
So Dr. Blake, what do we know about how this kind of melds in with the Pfizer and Moderna? And is the Johnson & Johnson something that would be targeted to a certain demographic, or how will those work? How will they merge?
Yeah, that's a great question. I agree with Dean. It is a great vaccine, but it poses new challenges in that it requires less refrigeration and only 1 dose. So there are multiple groups looking at, is this a better vaccine for certain populations, such as shut-ins or migrants or people who are in really rural areas. The White House came out 2 days ago and said they're distributing the vaccine evenly to all states. So it really looks like that decision is going to be left up more to a state local level. The concern is, even though this vaccine is somewhat less effective, but I agree with Dr. Watson, 0% death is a great number, that there may be a little bit of a bias distributing this vaccine exclusively to certain populations. So to best answer your question, I think that decision is still yet to be made, but I do think that vaccine mostly will be available to all of the public.
Okay, and you still don't really get to choose, right? I mean, how does that work?
Yeah, the federal guidance at this point is any vaccine center that's going to be giving out vaccine, you probably will know what vaccine they're giving before your arrival. Now, once you get there, no, there's not going to be a let me pick this one off the shelf type of scenario.
Okay, good. Okay, let's go to Claudia Blackburn, Health Officer for the Florida Department of Health in Leon County. Ms. Blackburn, lots of state news in the last couple days. The governor announced that soon the vaccine will be available to teachers and law enforcement who are over 50. He also indicated yesterday in Jacksonville that the overall age might be lowered to 60. I have like 7 questions about that, like how will that work? What does the process look like? If I'm a 55-year-old teacher, what should I be doing? If I'm a 62-year-old, what should I be doing? So why don't you just kind of tell us everything you know about how that's going to shake out?
Sure, it's a great question. I know there's a lot of interest and anticipation around the next set of priority groups. But at this time, at this moment, and it could be changing while we speak, we're operating under the existing executive order, which prioritizes, long-term care facility staff and residents, healthcare workers, people 65 and over, and vulnerable people as approved by the hospital. But we are obviously listening to the governor and preparing for various scenarios. We don't know if it will just be limited to federal sites for the teachers. We don't know if it will just be 50 and over, but we are planning to immunize law enforcement, firefighters if they're included, and the educators through the Leon County Health Department. And we're working with emergency management now to collect names, and we're preparing for these various scenarios. For the 60 plus group, we'll continue with our current process. So people can sign up at myvaccine.fl.gov for pre-registration when that priority group opens up, not now. And we will continue to work with our partners to immunize through provider offices, TMH clinics, FSU, FAMU, the Bond neighborhood, North Florida. And then when the amount of vaccine received into the county exceeds the capacity of our current system, we'll work with TMH to stand up a high volume community clinic. But right now we have quite a bit of capacity. We just need more vaccine.
So to follow up on that, Ms. Blackburn, I know our percentage of 65 and olders vaccinated is, if not the highest, one of the highest in the state. What is that number now? And what is the kind of, do you have in your mind a saturation number? I mean, obviously we're not going to get to 100%. I mean, I know that's the goal, but what in your mind is the number where it's really time to start moving on to folks who are more eager to get it than apparently some that might not be?
Well, I think we're about at that number. We're at 72%. 80% would be ideal, but I think we're sort of in that range where we could shift some and then continue to do the 65 plus. We do need to make more progress in the Black community. About 31% or 33%, I believe, of the Black community 65 plus has been vaccinated. So more work needs to happen there.
And is it the reason that 80 is topping out? Is that a statistical thing, or do we just assume that 2 out of 10 folks just don't want to get the vaccine?
I'm not sure that anybody knows the exact number for herd immunity. Somewhere between 75 and 80%, would be ideal.
Okay. Okay, great. Okay, so speaking of Dr. Robinson, CEO at Bond Community Health Center, the local coronavirus task force, which has a much longer name than that, recently met, and Ms. Blackburn was sharing some of the statistics, one of which she just shared about the vaccination percentage, and also that African Americans are significantly more likely to be hospitalized from COVID. We've talked about this before, but I was wondering if you could just share a little bit more about efforts at Bond and throughout the community to address this disparity.
Well, all of the doctors in town, all of the health centers in town, we have a all hands to the pump type mentality. So when we have a patient that we know is COVID positive, just like your doctors reached out to you and we're in close contact with those patients. We're helping them get something called pulse oximeters, which checks your oxygen level at home. We're giving people something called a peak flow meter, making sure they get those things. And we are constantly back and forth with them, making sure you don't wait till the last minute until you go to the hospital. People who have tested positive, like you, Skip, we're knocking on their doors to see if they will now donate plasma, because one tool we do have is something called the IV monoclonal antibodies. If we think people are at a risk of having a bad outcome from COVID or that they may need hospitalization, we can refer patients to get the antibodies. The only way we can get the monoclonal antibodies are for people like you who become heroes and donate plasma after they've had a bout of COVID. But I also want to say the health centers and the other doctors, we're scouring our electronic health records. We're trying to look to see who has met criteria for vaccination and separating those between people who have problems with access to getting it and they want it, that's an easy fix. And those who are reluctant, that's a little more difficult fix. And so that's why the activities of this task force is so important. I want to say something though about our private physicians in town. I get a lot of people calling me, they're angry. I went to my doctor and he's not participating or she's not participating in giving COVID vaccines. I have to remind the listeners that the vial that has the vaccine in it has either 10 or 11 shots or maybe 5 or 6, depending on whether it's Pfizer or Moderna. And a lot of the doctor's offices are not providing the vaccine because once you open it, you have to make sure that you have given all of that vaccine within a certain time frame or the vaccine goes bad. So for a lot of doctor offices, they don't want to risk the chance of wasting vaccine. So I needed to say that because I'm here, my colleagues being blown up by my patients saying, well, I'm over here because my doctor won't give me the shot. And then lastly, when we talk about hospitalizations in African Americans, we talk about those things we call the social determinants of health, where you live, where, what type of work you do, what's your poverty level, what's your access to care. Those things are cumulative, those things are additive, and that's a longer conversation for a different forum, but all of that plays a role because anytime you're starting if your starting block is behind everybody else in a race, then you have a harder time catching up. Now, the number that really bothered me when I heard was that only 11%, and you can correct me if I'm wrong, Ms. Blackburn, 11% of all people who have been vaccinated in Leon County are African Americans. And that disturbed me because we have a large percentage of African American professionals and highly educated African Americans. And if that 11% number is correct, then that really shows why the activities of this task force is going to be so important. Getting the word out, educating, and convincing people to get vaccinated. I may have that number wrong, but if that's right, we really need the task force. We need people like institutions like FAMU to get vaccine to people in places where people are comfortable getting it. I know it was a long answer. It's a huge topic, so I'll stop there.
No, that's good. And I want to follow up with Ms. Freeman on this, but first, Dr. Robinson, there is a follow-up question about the donating plasma. What if I've been vaccinated or if I've been infected? Talk about the optimal timeline for when I should donate blood.
Okay, in the Hollywood Squares version of this, I am going to punt to Dr. Watson.
How unfair can you be, right? Yeah. So three separate things. One is there is some issues with blood shortages, as everyone's aware, and so donating is important, whether it's a pandemic or not a pandemic. So people need to be out donating for various reasons, not just for the pandemic. And then when it comes to donations for plasma back for the antibodies, which is what Dr. Robinson's talking about, they really want, there's actually a strict guideline on when you can donate. And what I would suggest everybody is to go to OneBlood, to their website, and look at the requirements related to donation. So typically we're looking at 30 days post infusion or infection, sorry, for the donation. And then the other part of that is if you have been vaccinated and you were never infected, and I'll remind you that you will be tested. They'll test you when you get there to make sure that you're not infected, but you can donate plasma in general for the needs that we have in the hospitals. So 3 different topics, right? You do need to donate blood. You do need to donate plasma. Even if you've been vaccinated, you're clear to go. You're good to go. Vaccination has nothing to do with it. Go donate. And then if you've been infected, go to the OneBlood website and follow their protocol.
And which are the most valuable of those? What's the blood we need the most?
I would just tell you that blood in general, if you donate blood, we extract all of those components from your donation. So just donate. Okay.
So Ms. Freeman, back to the issue of race and the hospitalizations and the vaccinations. Are you in a situation at Neighborhood Medical Center where you've got a long waiting list of African Americans that are ready to get this vaccine and can't get it? Or do you have a demand problem, not a supply problem? That's what I'm trying to understand is this, gosh, we've got so many African Americans eager to get the vaccine and we don't have supply for them, or we've got kind of a recruitment problem and supply isn't the issue?
Good afternoon, everyone. Right now, supply is not the issue for Neighborhood for the moment. Hear me when I say the moment, because I can imagine that won't be the case for long. But we have a list of patients that we're reaching out to who are African American and who are ages 65 and up. But it is definitely taking a lot more of us educating the patients on the benefits of getting this vaccination. So that's more of taking us more time than just actually doing the vaccine process. So right now we have a good supply for now. The more and more that we get out there and educate the community and talk to the people who are coming for the vaccinations, and they spread the word to others that they know who are eligible and who happen to be African American, we see those people coming in for the vaccine. So we know that our communications and the education and outreach is working.
And either Ms. Freeman or Ms. Blackburn, there is a statistical issue here, right, where a lot of people just aren't answering the race question. Do y'all know anything about that? I think it was, am I wrong about that?
Do you mean on the vaccination forms?
Yes.
We have not.
Aren't there a lot of folks where we just don't know what their race is?
Well, at Neighborhood, we haven't seen that. We've been able to document that as required on the form.
Okay. Okay, so finally, I want to welcome Kevin Peters, who's the Director of Emergency Management. And I know, Kevin, you're doing with the county a lot of logistics and coordination. Give us a quick update on what's happening with you.
Yeah, you know, some things still are the same. A lot of conference calls every week with all of our partners, many of which are the same representatives on this call. From a county point of view, partnering with Dr. Robinson and the Bond Community Health for a walk-up testing site on March 1st, the Fort Braden community. That'll take place at the Jane G. Sauls Fort Braden Library, our county library in Fort Braden, on March 1st from 10 a.m. to 2 p.m. And I think I've got a little bit of new news here about individuals that may be looking for transportation assistance to get to vaccine appointments. I got a note from Volunteer Leon about a partnership that they've been involved with United Way, 211 Big Bend, and Lyft, the rideshare company. The program starts next week, March 3rd. And it's going to be a partnership where individuals that are looking for transportation assistance to get to a vaccine appointment can coordinate a ride through 211 Big Bend, and they'll get be scheduled with Lyft to get a ride. Now, there's a caveat. It doesn't apply to the drive-through. So the clinic that Claudia and her team run at the health department, for example, it wouldn't apply to that. But if you had an appointment at one of the pharmacies, like a Publix, Walgreens, Sam's, that are part of the federal vaccine program, or if you had an appointment at FAMU for their vaccine site, it would apply in those scenarios. It can take you door to door from your home to one of those walk-up vaccine sites. To schedule, I'm going to go slow here with phone number. They can contact 211 Big Bend by calling 50-617-6325. And Skip, I can make sure that gets emailed after this, so any follow-up materials that gets put out, the team will have it, so it can be made available. But that's kind of a new thing that came up this week.
That's great. Thank you, Kevin. And if you want to know what the one of the surest bets in life is, it's that the UPS guy will drive up in front of my house in the middle of this webinar. So he's like batting 1,000 so far. Hey, Ms. Blackburn, we have a question just about the overall stat trends for cases and hospitalizations. I know that is for the most part good news. And maybe Dr. Blake and Dr. Watson, you could just quickly share us as well for y'all the key stats on hospitalizations and cases.
Sure.
Yeah, I'll go first. Go ahead.
Okay, well, so good news. Our positivity rate for the last 2 weeks has been 4.33%. That's from February 12th through February 25th, with 76 cases per day. So we've continued just to stay under 5%. So that's good. No new cases of the variants. We are continuing to see cases disproportionately in the 18 to 24 year age group, 31% of our cases versus 17% of the population. We're looking closely at those 65 plus folks. We have had about 5% of our cases, and they're about 13% of the population in that age group in the last 2 weeks. Maybe Dr. Blake and Dr. Watson can talk about what they're seeing at the hospital, because that's the number we're really looking at. Would love to see that to 0, but not there yet, but don't know how many of those folks are ending up in the hospital. So that's what I have.
Dr. Blake, Dr. Watson?
Go ahead, Trey.
Yeah, we're seeing the same trend. Our hospitalizations dropped as low as 13, which for us is fantastic. At one point, we only had one COVID patient in the ICU. Again, that is fantastic news. We're also seeing a decreasing length of stay. So I agree that the elderly population vaccine efforts really seem to be paying off in our hospitalizations.
Yeah, I agree. We're down to 12 through the whole system. Same thing.
Okay, good. Well, I'm a little embarrassed that a couple questions have come in about me wanting to know how I kind of was treated. And so there's one about did I get the monoclonal antibodies and remdesivir? I did not. My treatment was antibiotics and prednisone, which when the prednisone kind of, I think we dialed that in, really made a difference for me, really helped my lungs and then of course all sorts of cough and inhalers and things like that. So I appreciate that question, and I didn't quite qualify for some of that heavy duty stuff, thankfully. So I'm happy to answer that. And I wanted to ask you, Dr. Watson, about post-infection testing and determining when someone is no longer contagious. My doctors indicated to me that you can test positive many weeks after having COVID, even though you're no longer contagious, and have actually suggested that those tests are kind of pointless. But I also know there are workplaces that are requiring a negative test to return. So how do you reconcile those things, and how should that work?
Yeah, everything you said was correct. CDC is very clear. And early on, for everybody on this panel, as we watched this disease progress over a year ago, we were shocked to find our tests coming back positive after 14 days, and we assumed they were infectious. But there are dead particles. They have identified dead particles that still register with the commercial tests that we have. CDC is very clear that if you are 10 days out and symptoms improving, you are not considered infectious. And why companies or corporations continue to try to, cause people or force people to get tested when there's no evidence basis behind it, I'm at a loss, because it actually affects us. They get in line for tests. They affect people that actually need to be tested. These individuals do not need to be tested. They consume resources that do not need to be consumed. And it's all because of a total misunderstanding in the corporate world, which makes absolutely no sense to me. Like, we should be using evidence-based science to direct our care. And the evidence-based science says that one test, if you are positive, follow the CDC guidelines, period. There are no, that's it. So anybody that's using any other guidelines out there, we would love to have a conversation about that and help educate them a little bit.
Okay, so just to be clear, you're saying that a post-infection test is really pointless and worthless.
Pointless, and it can be positive for beyond 90 days. So you could have somebody out of work for 3 months because somebody is following a guideline that has absolutely zero evidence, zero.
Okay. Well, that's, I think, important information. Dr. Blake, I wanted to ask you about people that have already been vaccinated assembling. And I know as the numbers start to get better and the vaccination numbers start to go up, people are gonna be ready to kind of get back to normal. Why can't a bunch of already vaccinated people get together? And if it's, well, because it's 90 or 95% effective, not 100, then when do we ever kind of fully get back to normal? What does getting back to normal look like?
Yeah, that's a great question. Not all the experts agree on this, and I think research will continue to help us answer this question. Most experts, including the White House experts, believe if you and your family member have been vaccinated, and the key is that you're out greater than 2 weeks with no symptoms, that gathering to dine is reasonable. But it really comes down to risk, and everybody has to make the risk versus benefit assessment for themselves. If you're a high-risk person, you're a physician, nurse caring for COVID patients, your loved one has decreased immunity or advanced age, you're going to have to assess that risk on your own. But most experts are saying if you are greater than 2 weeks out, you're asymptomatic, that a small gathering with still taking precautions, hand washing, distancing, stuff like that, seems reasonable. But I think there'll be a lot more guidance to come on this issue. The CDC is also reconsidering things like quarantine for people who have been vaccinated. So I think we'll see a lot more information come out in the near future. You're muted, Skip. The COVID is affecting.
Whoops. Sorry. I'd like to just pause and thank our WFSU audience for joining us. We're going to let them go and continue with this discussion. Sorry about that, my first little mute hiccup of the day. So I want to thank you, Dr. Blake, that answered that question very well. I'd like to come back to Dr. Robinson for a viewer question, which is, what is the physician, there's still confusion about the physician referral process. I know you talked that a little bit. Why can't a primary care physician refer me? Why are they able to, but not a specialist? And then there's also a question here that just came in about, are there any places a primary care doctor can refer me besides the hospitals?
I said, All right. While the specialist can't, I'm not sure. So I'll put that to the side and Dr. Watson, because I know TMH is handling those referrals. Well, we have new sources now, new places to be vaccinated. So I assume you're talking about people who are in the vulnerable population, they're identified as vulnerable patients, not 65 and up. Right now, this is directed by the state, and TMH is the designated site to receive vaccinations if you're in that vulnerable population. So you just can't show it with something scribbled on a piece of paper or something. You actually have to have a referral by your physician saying you're vulnerable, this is why, please, if you have vaccine, vaccinate. There may be a spillover site at FSU now, I'm not sure. So I'm gonna let Dr. Watson actually handle both of those.
See, we're gonna start swapping questions here. Temple. So thank you, Temple. So yeah, the state designates, well, according the governor actually in his order had designated hospitals to come up with the criteria, and this specific hospital, TMH, uses the CDC criteria to determine who qualifies as vulnerable. And back to Temple's point, she's always on the money, is that really it's up to the providers to use those criteria to make a determination. They can then subsequently notify TMH. We have numerous modes of communication or means of communication that have been sent out to all the primaries. Why the primaries initially? Because the primaries have the best and the most knowledge about the patients in the community, and there are more primaries throughout this community, which means that we could have a wider net, if you will, to those affected, and great partners on this call as well. So they're very involved in this. Now, remember, I just want to reemphasize this, and Claudia's mentioned this, Jeanne's mentioned this, Temple's mentioned this, Trey's mentioned it. We have limited supply. So the hospital gets a very, very limited supply, and it's not guaranteed. So this week, today, I'll get a call from ACA to tell me if I'm getting some next week or not. And I wait, or an email actually, but I have called them. So we don't know. We're still scheduling out, but it's really a game. And when that winter storm hit, as Claudia knows, we got blown up because we got no vaccine for vulnerable. We had 1,000 patients scheduled. So then we had to mix and match and come up with a game plan. So it's very difficult. What we're doing now as an organization, we take our designation, and we've already communicated with the Department of Health, we've communicated with State Department of Health and Leon County, and with ACA to get permission to designate other sites to help us. And many on this call are designated to help us. So once Claudia says, hey, we've really done the best we can do 65 and over, and together we look at that and say we've done the best we can, we start focusing on vulnerable as a team. TMH designates, we look at bond, we look at neighborhood, and we say, we're going to designate as a team and you can help us with those patients. But it all goes back to vaccine supply. If there's not enough vaccine, it doesn't matter who we designate. And the final thing for primary care is we have gone out to some of the TMHPP specialists, HEMONC, right? A lot of vulnerable patients there. We've gone out to pulmonary, rheumatology, and we've partnered also with the other local oncologists in town to make sure we're affecting those patients as well. So it's not just primary, but we have to have some control over it because we have very limited supply.
Great. Hey, Ms. Blackburn, we've got a number of questions in about folks that are homebound, bedbound, and is there anything in the works to help get vaccine delivered to people who really aren't in a position to that aren't mobile? What can you tell us about that?
Yes, we've been working with home health, with elder care. Also, the paramedics have been helping with that. So if there are people that need that service that are not being addressed through their care provider, then they can give us a call and we'll help them to get linked to service.
Okay, so they should call the health department. Mr. Peters, are y'all playing any role in this?
As we find out these things, we certainly would work with Claudia to coordinate that. But Claudia through the health department has the supply, and they would have to schedule the vaccinators. She's overseeing the actual administration process. So we'd have to work closely with Claudia on that.
And honestly, that should really be a rare case because most of those folks have a healthcare provider, and they should be working through their healthcare provider. And if they can't leave the home to go to their healthcare provider, whatever the method is for them to get their healthcare, if it's home health or whatever, then that would be how they get their vaccination. But if none of those things work, they can certainly call us and we will help them.
Okay, great. We have a question, and I'm gonna, I don't like doing toss-ups, but I'm gonna do a toss-up here. What is the latest with our prison population, jail and prison population being vaccinated? And particularly, I guess, the folks that are 65 and over that are in prison. Who has some information on that for us?
I don't have any information, but, and I'm going to be very careful because I'm very passionate about this. We have a lot of jails in Florida and a lot of prisons in Florida and a lot of correctional institutions, and each of them has their own set of rules, and I don't know who makes the rules. But I will just say that healthcare is a right. It is a civil right. Immunizations is a part of healthcare. And somebody that is in a different pay grade and have a different level of authority probably would have to give you this answer on this call. If you had an outbreak of TB or something of that sort in the jail, somebody would be doing something about it. And I'm just concerned because these are our neighbors, for instance, that are in the Leon County Detention Center. People get out of jail, and these are our neighbors. So to vaccinate the 65 and up, I don't know if that's going to move the needle at all. I don't know if that's going to be protective because it's a jail setting. So how we address this, I'm not sure. But my personal feeling is that the prisoners in the correctional institutions should be vaccinated. They're living too close together. They can't protect themselves. They can't socially distance. I know that we don't have a lot of vaccine to go around, but somebody needs to be thinking about this. This is a right to have access to preventive health care. And that's what the COVID vaccine is. And I'll stop there before I get into some kind of trouble.
Well, there's no trouble in speaking truth. So thank you for that response. And we will effort to see if we can get some more information on that down the line. I think that's it's an important question. Dr. Blake, there's a question about, do you have any new information about the benefit of delaying the second dose for a higher protection rate after 6 weeks versus 4 weeks? Anything new about that?
No, nothing official has come out. There is no advice from the CDC or the federal government on purposefully delaying the second dose.
Okay. Ms. Blackburn, getting some questions about, kind of what returning to normal might look like and the timeline for that. How are those decisions going to get made? I mean, I know we've got President Thrasher indicated that there'd be in-person commencement in the spring. And I believe he also indicated this week that there'd be a much more of the plan for kind of a more normal fall term is what's in his head. We've got Easter season coming up, which is a time when folks tend to get together in church. What does that decision making look like, and what do you anticipate life kind of starting to look like here over the next 3 to 9 months?
So you're asking me to forecast. I listen to a lot of the experts and they don't agree. So I'm certainly not in a position to forecast. I really think that we have to take this one step at a time, watch what happens with this virus, watch what happens with the cases. And I think that decisions are going to be made as we learn more. Right now, the latest update from the CDC regarding faith-based organizations, this was on February 21st, so just a few days ago. The CDC recommends that you do not gather with people who you do not live with at this time. Attending events and gatherings increases your risk of getting and spreading COVID-19, and stay home to protect yourself and others from COVID-19. That has to do with faith-based gatherings. So there's really been no change in the guidance to this point. It gets back though to what Dr. Blake was talking about. If you've got a group of vaccinated people, they're going to decide what kind of risk they want to take. So we're not there yet. I know people want to be, and I'd love to make it so.
I understand. Doctors Blake and Watson, we're still getting some questions about these variants. Is there any reason to believe that the vaccines are less effective against these? Why do these variants really even matter?
I saw Trey unmute, so I thought he was going to talk. And now, so let me, we've talked about this numerous times in the past, is that variants occur because that's how they survive, right? And every time everybody on this panel says the same thing, I'm not worried about a variant, I'm worried about you getting vaccinated, because what we know is that in all the studies to date, and again, we've only been in this game for a year, that our vaccines, our current vaccines, are capable of handling these variants. Now, what you're going to read in the literature is, well, they're less effective. Now, read the fine print, okay? They're less effective, but they're effective, okay? Meaning that the antibody levels are not as high for the variants as they are for the original virus, but they still work. And the other cool stuff that is going on is, and many of you probably saw what came out in the news yesterday, is that they're even seeing now with the Pfizer itself, and I'm sure we'll see it with Moderna, is that individuals that have been infected, You may only need one dose post-infection to maintain immunity. The other things you're seeing happening right now is Moderna is already working on studies to change their structure to affect all these variants rapidly. Remember, the mRNA vaccines are easy to manipulate, meaning that we can change them rapidly to affect various variants. And so just to reiterate, just because it's less effective doesn't mean it's not effective. It still works. You're still producing antibodies. So lots of great news. And I think people need to focus on all the positive news coming out. These things are working. The other thing I would tell you is when you talk about variants, go and look at the data in these countries where these variants exist. Yes, they're easier to pass along. Look at their hospitalizations and their infection rates. They're all dropping like a lead balloon. All right, why? Because the vaccines are working. The variants are there, but the vaccine is still working. So let's focus on the positive. Let's get vaccinated as soon as we have enough supply. And when it arrives, we'll get it in your arm rapidly. And that's what we need to be talking about is the benefits. And let the virologists and the immunologists work with these companies and redesign the vaccines as we need them. Yes, you may have to get a booster in a year. Yes, the majority of these things work for longer than 3 months. But we talk about 3 months because that's what the studies, the 90 days, because that's what the studies were based on. This is so much positive news. It's really what we should be focusing on.
You want to add anything to that, Dr. Blake?
I think he should.
No, I completely agree. There is no evidence to date that any variant should give us tremendous pause on getting vaccine. I agree, people have to get the vaccine. The effectiveness, if it goes from 90 to 85 to 84 or 80%, that's still very, very effective, even when compared to the flu vaccine. So I agree, there's no variant out there is there any reason to reconsider getting vaccinated?
Look, this panel has taken time for an hour plus for 6 straight weeks. I want to thank all of y'all for being on this call and continuing to share information. The questions keep rolling in. The folks keep signing up to participate in this. And so demand is high. We got an information demand for sure. So thank you for doing this. If you're interested in more information like this, March is coming up. It's Colon Cancer Awareness Month. TMH will be hosting a virtual discussion on the truth behind colon cancer screenings. Join oncologist Dr. Amit Jain and Dr. Todd Morris as they share vital information about signs and symptoms of colon cancer, why annual screenings are necessary, and how COVID-19 should not delay you scheduling your screening. That will be on March 10th on Zoom at 1 o'clock. You can register today at tmh.org/colon-chat. Thank you so much for all of your questions and for your participation into the panel. And we will see you next Friday. Have a great weekend and be safe.